May I request now Senior Assistant Professor Dr. Kshitij Shah from the Department of ENT and Head Neck Surgery, Sion Hospital, to please make his presentation.
Thank you, Renuka ma'am. And hi, good evening, everyone. At the outset, I'm very grateful to Alchem to actually have put this platform together where we at Sion have come together to present our views on, I would say, the current flavor of the season, mucormycosis, because there's so much going around. And to keep me on track over the next, say, 10 minutes, I'm going to time myself. I'm going to share a small presentation. So I'd like to actually title it as a revisiting mucormycosis and give the perspective of the ENT surgeon as to how we have seen this evolve. We have learned a lot through this experience and are still learning possibly every day. But let's just review what do we already know. And it's been excellent listening to Dr. Swati Chavan before this, Dr. Baveja ma'am, Sudhir Pawar sir, and I was mesmerized by Anaga madam's talk because she can teach so much by just one image. But yes, what we as clinicians, as ENT surgeons do know is that we know it's an aggressive and angio-invasive fungus. We know it causes ischemic necrosis. That is why this blackening happens. We know it is potentially life-threatening. And the usual patient profile is that you have patients who are uncontrolled diabetics, immunocompromised, maybe chronic kidney disease. And now, yes, add to it, a lot of our patients, almost most of them have had COVID in the last 1 to 2 months, possibly. Some of them even 3 weeks post-COVID. So that is there a window period to look at? No, you've just got to have your antennae up all along. I think Dr. Swati presented really well on what you should be doing with the diabetic patients. What we also know is that as clinical presentations go, we do see a black SCR in the nose or sometimes in the palate too. So we need to examine that. I will go on to talk about the rest because the ptosis, chemosis, and periorbital swelling, which the next speaker possibly will cover up, lacrimation, proptosis, diplopia, ophthalmoplegia, sometimes total blurring of vision, vision loss. These all are orbital symptoms. But what as ENTs we must keep a very high index of suspicion for is for this facial numbness, because as patients are becoming more aware of this, they are coming in possibly a little earlier, and it would be fantastic if we as clinicians could pick up these early cases when they just present the facial numbness with a high index of suspicion. So mucormycosis is not a new disease. I love the slide where Dr. Baveja spoke about the data that Sion Hospitals already had in 2018, 19, going on to 20. COVID has been around for more than a year now. But yes, we are seeing a significant increase in numbers because in the first 6 months of the year, we've already covered the quota of last year. And we were, yes, at least at the start, we were taken by a little bit of surprise because we were seeing a lot more mucus coming up. This experience has been completely collective. I think everybody's spoken, it is completely multidisciplinary, and that's why hats off to Renuka ma'am for putting this panel together where you've got perspectives of different faculties and different departments coming in. Yes, the clinically treating people are medicine, ENT surgeons and ophthalmologists. The radiologists are an invaluable tool to guide us to what exactly are we looking to treat and how much could it be worth in prognostication. The micro and the pathology departments are the backbone because they are the ones who actually confirm this diagnosis for us. Yes, there are signs on CT and MR which are almost pathognomonic now, but the final confirmation is by the microbiology and the pathology departments. Our hospital administration has been invaluable to us in providing medical as well as support in the surgical part of it. They have also done their best to actually align one of our wards and designate as a special mucor ward so all departments can come together for optimal patient care. I'm deeply grateful to them. I'm going to quickly revisit the pathogenesis. So we always knew that there was avascular necrosis happening. But what we have realized is that in the early phase, when it is limited only to mucosal invasion, and when there is hyperemia of the mucosa, and this is when now when you correlate with what Dr. Baveja ma'am had spoken and what Dr. Anaga Joshi just showed on MRI, in the early phase, when there's hyperemia, the MRI will actually show hyperintensity. And that at that point of time, the disease is possibly still epithelial invasive in the mucosa. And then as it goes on to a late phase, it causes invasion of the vascular endothelium and causes avascular tissue necrosis, which leads to the blackening and the charring or the S-char that forms. And we must keep in mind that spread of infection is not always contiguous. In fact, because it is airborne, you could have different areas of the sinuses affected. You could have the orbit at different parts affected. there is a lot of hematogenous spread, because as it invades the vascular channels and the endothelium, that is where it starts causing thromboembolic phenomena. We'll talk about that more as we go ahead. So what's the ENT surgeon's perspective? This is a fungal infection, so obviously antifungals are one of the mainstay in treatment. There is amphotericin B, conventional or liposomal. There is posaconazole and isavuconazole now. It is imperative to control the medical comorbidities. That is, you already heard Dr. Swati talk about it, that controlling the sugars, the electrolytes, and possibly even the kidney functions depends on the patient profile. It's extremely important. From the surgical perspective, surgical debridement is an integral component of the treatment. The principles of that are to excise dead, decaying necrotic tissue. How does that help us? It helps us to reduce the fungal load so that the antifungals that are being given will possibly act better on the tissue which has fungus left in them. So the tenet of how we base our surgical decisions is to be as aggressive as possible, and yet to consider the morbidity that we're giving to the patient. And sometimes it becomes a tightrope act to decide how much to operate in a particular patient. How much can we operate? So over here, you've got a picture, and let me get the laser pointer on if possible. All right. Here you've got a picture which shows that, okay, moving on. You've got a picture which shows that endoscopically, we have resected the septum. We've opened the right maxilla, the right sphenoid, demarcated the right orbit. You can already see the left inferior turbinate on the other side. You can see the left nasal cavity. So almost the entire nose, so as to speak, on the right side, sinuses and the septum has been debrided. And this is a surgery where we are not looking to spare mucosa, unlike functional surgery, because the mucosa has fungus in them. So the mucosa is also to be debrided completely. When it comes to debriding the palate, we usually do it transorally. So you have an approach and access through the nose, and you have an approach through the oral cavity. And again, you debride whatever bone has got necrotic. The palate also goes with respect to that. When it comes to the what new are we doing with respect to this disease? There is a lot of talk going around with respect to debriding the infratemporal fossa, and yes, we have started doing that. In fact, let me show you a short clip of what would debriding the pterygopalatal and infratemporal fossa look like. And also, I know Dr. Akshay is going to speak a lot more on the orbit, but I'm going to show you a very short clip of how a medial orbital debridement would also look like. So give me a second to stop my share. So the first video that I'm showing you is of a patient who, after sinus surgery, this patient had disease in the pterygopalatine fossa and in the infratemporal fossa. And this is undergoing debridement over here. You can use even a micro debrider, because unlike normal tissues which would bleed and you'd have vessels which would be spurting, these tissues are dead to a certain extent, or at least they're avascular to a great extent. So you see that aggressively a micro debrider is being used over here. And it's important to understand what is the end point of resection. So just to orient you, right nasal cavity, medial pterygoid plate, the pterygoid base, surgery going on in the right infratemporal fossa. Now the mucosa has this typically, whitish sluffish look, almost like how a cadaveric mucosa would look like. But the end point of surgery is as you start getting fresh bleed. So you want to clear off all the slough, whether it is with a debrider or with a plain forceps. That's a surgeon preference. But as you finish clearing off most of the stuff, you will come across areas that start bleeding freshly. Here you can start seeing pterygoid muscles coming up. The muscle fibers can be seen, and that to an extent is the end of surgery. It's again a fine balance to know here, because we can do a lot of things surgically, and that is why sometimes deciding when to stop is also critical. But that's where we decide how to limit our extent of surgery. Let me quickly show you the other video. This is a case which had orbital involvement, but on MRI that is, but the vision was preserved. So what we chose to do in this case is, after an orbital decompression, we decided to go ahead with a medial orbital compartment debridement. So that is, the lamina preparation is already taken off. That's incising the orbital periosteum. You start seeing the fat of the periorbita, and this fat is not looking, what the normal fat looks like. It looks a little tawny brown, so as to speak. And even here, you can use a debrider in a controlled fashion. now don't use the oscillate, but the forward mode, and gently at about 500 to 1000 RPM, the fat can be slowly debrided. Again, the end of surgery here is good because we're debriding the medial orbital compartment endoscopically. The end of surgery would be to identify the medial rectus. This surgery, needless to say, cannot be done without an ophthalmic or an oculoplastic surgeon actively on board. So in this surgery, we've had their assistance where they have slinged the medial rectus muscle. And as we come close or as we are confused as to what tissue it is, they help us by tugging the muscle. And you can take a look over there. That's the medial rectus coming into view. So it's I won't say easy, but it gives the surgeon a lot of confidence to keep debriding the fat because the muscle is taken care by the ophthalmologist or the oculoplastic surgeon. And the idea is to take off as safe it is without causing morbidity to the patient that he currently doesn't at least have. The orbit is an entire topic altogether. I'm not going to go into that. Dr. Akshay will be speaking more about that. So getting back to my presentation. Yeah. So yes, infratemporal fossa surgery should be considered. It depends on a case basis because it depends on what kind of patient you're operating. Orbital surgery has been already known in terms of orbital exenteration, and I will talk about a scoring system that we had come up for the same. So we've been doing orbital exenterations for a while, which is obviously transconjunctival, and along with the ophthalmology department who would help us with the enucleation, and then combined together, we would take out the periorbital contents. One dictum that we strongly advocate is do not debride the skull base. Yes, infections do go intracranial at times, but that is where we've got to be uh, tempered as a surgeon, because ultimately we are treating a fungal infection and the idea is to treat the patient. So if you start taking off the skull base and start taking off the dura and cause CSF leaks, then I believe the morbidity would be significantly more, because anyway the patient is fighting for his life at a particular point of time. Despite the skull base bone being ischemic, we would leave the skull base intact and we would not want to expose intracranial structures. You have seen plates where meningitis has already happened by the disease also. So definitely debriding the skull base is not going to, that barrier is better to be kept. So what are the common surgical dilemmas that an ENT surgeon would come across? And this is what I would again focus in the next minute or so. The most important question very often is how much to debride. Well, I already explained that you debride as much as is required, be aggressive. And for me, when I teach my residents, the end point of debridement is when you get fresh tissue bleed. It also makes sense and appeals to logic that if you've got fresh tissue bleeding, the antifungals that are given intravenously are also going to reach there better. So how much to debride, that would be my answer to it. What morbidity is acceptable? It is on a case-based scenario. There have been patients where we have taken out both the eyeballs and the orbital contents because the patient had a good prognosis. There have been cases where we've debrided the entire palate because the patient has a good prognosis in terms of his overall prognosis towards life. So yes, we would always value life over an organ. But at the same time, if you have a patient who's moribund and the prognosis is not very good, I would not go about aggressively debriding such patients. Are we surgically curing the disease? This is something which we must put in perspective, that we are not surgically curing the disease. We are surgically debriding what is decaying, what is dead. We are reducing the fungal load to the best of our ability. It's not that we're taking a cancer off and it's not an R0 resection. So we are surgically decreasing the fungal load and the tissue load, but we're not curing the disease. Antifungals have a definite role to play and they must be given for the complete dose. Is there any particular surgical approach to follow? No, not really. I mean, you can't take off a palate through the nose per se. So there, going through the oral cavity makes more sense. If you'd want to exenterate the orbit, going transconjunctival makes sense. Transnasally, endoscopically, you can take out as much as you want without actually damaging the anterior pillar of the nose. So yes, would we be hesitant to do a modified Denker's? No, not at all. If it deserves a modified Denker's, we'd go about and do a modified Denker's medial maxillectomy. But the case I just showed you where you have infratemporal fossa clearance, even in that case, if the anterior tissues are preserved, it does not make sense to go about taking off tissues just to be able to see something, because the endoscope gives you the luxury to see much beyond by putting it in the right place. So any particular surgical approach? No, whatever each patient deserves, it has to be customized to a patient. One approach can't fit all. Should we violate the external facial tissues? Now that again is a case-based scenario, because let's say you have a good prognosis patient and you've got external involvement of the skin. At a certain point, primarily or secondary as a debridement, it might make sense and even have the plastic come in reconstruct. But as a first approach, if the skin is involved and if you give the patient a ghastly wound, anyway these patients are immunocompromised, it I would be of the opinion to preserve the external facial tissues. So even the incisions that we take are mucosal, which are going to heal. We do not take Weber Ferguson to approach this. We do not excise of tissues and do a plastic reconstruction, because treating cancer is different. Here, overall, the tissues are loaded with fungus. That is why I think that's where a surgeon, as you grow in your career, you kind of decide to temper of how much to excise in a patient and how much to look at a second stage surgery if required. So what's the protocol that we follow in our department and a Sion hospital? A clinical history and an examination, and that would include a thorough clinical history, medically, an ENT examination currently at this stage. And let's say that this comes to a suspect of mucus. So typically a scenario would be post-COVID, 1 month is having numbness on the cheek, and then you look into the nose, maybe you can see a blackish char, you're suspecting mucus. He may have other symptoms. The first things that we'd like to do is do a diagnostic nasal endoscopy, take the crust and send it for a KOH mount at least initially, do a CT, PNS, and an MRI with contrast, as you've just heard, to assess the extent of disease. And amphotericin B, subject to the comorbidities, can be studied empirically for the first maybe 24 to 48 hours till we are awaiting the diagnosis. KOH mount, usually in our place, we get the result in as quickly as 2 to 3 hours. Let's say the KOH mount is negative and the CT-PNS still shows sinus disease, then we would go ahead with, yes, I'm calling it a FES, a functional endoscopic sinus surgery, but we would be debriding of certain bit of mucosa to take histopath, to take fungal culture. The idea of the surgery would be to take off the disease that is seen on the CT, ventilate the sinuses, clear the disease. Sometimes mucor can be an innocent bystander, but the histopath is the definitive thing. So let's say the histopath is negative, then it's important to review the diagnosis. We would at that stage stop amphotericin B because it has certain toxicity. And I'll come to the review of diagnosis in the next slide or two. But let's say the KOH mount is positive. Then what happens next is the CT and MRI with contrast is already done. It helps to prognosticate the extent of the disease. An ophthalmic evaluation at this stage is absolutely imperative, whether there are signs or symptoms that the patient has or not, because there are a lot of things that the ophthalm can pick up on a fundoscopy. The MRI may show things which are not yet clinically evident. Amphotericin B obviously continues, the medical management continues, and we get the anesthetist on board to give us a fitness for debridement. Surgical debridement, as I just explained in the couple of slides before, would be as indicated. Orbital surgery, we use the Sion hospital scoring system, and I'll come to that in the next 2 slides. We use this extensively. I'll share with you all the logic of using this. And amphotericin B continues. What do we do next after debridement? Once the patient has reached around 2 grams of amphotericin B, we will repeat a check endoscopy and do a biopsy. Let's say the biopsy is a negative report. Yay, that's good. The treatment at this point concludes. Serial follow-up and monitoring is going to be imperative, because these patients may have later on things coming up which are not seen at that first check endoscopy. We are also strongly now considering posaconazole on discharge. It's as I said, it's evolving. But yes, when I had a chat with Dr. Bradu ma'am, she did mention that she's been using posaconazole post-operatively once the ampho treatment is over on discharge. And it is oral, so it can be given that way. What if there is a positive report at 2 grams of amphotericin? We would post the patient for a surgical redebridement of that local area. Amphotericin B will continue up to 2.5 grams, and we would repeat the check endoscopy and the biopsy again. If it is still positive, we would go up to 3 grams, and at that point definitely add posaconazole, because it is said to be recalcitrant mucormycosis. We are still monitoring the nose and the orbital tissues, because there would be no other way to monitor the intracranial status per se of the patient. This is the scoring system that we have come up with. So this is not something that's happened now. We actually did a lot of work back in 2017. You saw Dr. Baveja ma'am presenting data of Sion Hospital then. We have encountered a lot of mucus in the past, and we had done this study in 2017. It got published online in 2018. And one of the biggest dilemmas is, when do you actually exenterate the orbit? Because yeah, we debride the nose, but to lose an eye is one step further. So this scoring system, which we devised together in conjunction with the ophthalmologist and the radiologist, it had three parts to it. We had clinical symptoms that we looked at, we had ophthalmology findings, and we had imaging findings at that time on a CT scan, and we gave each of it equal weightage of 15 points. And then with analysis of the data, we decided that if a patient falls in a score about 23 out of 45, then it would make sense to go ahead with orbital exenteration. This paper is freely available. It's published in iJohns, and during this time, it's been made a free access paper. I would encourage you to read it. The data that we got, that in the 15 patients we had analyzed in that study, we had taken off 8 orbits, and 7 of them were positive, and the 8th one who was negative, there was a reason that we'd done the orbital exenteration. So we felt very vindicated, and we've been using this scoring system extensively in our current patients too, to make a decision for orbital exenteration. Yes, the MRI is very useful, radiology is helpful, but I think this clinical system has, for me, it has stood the test of time currently. I'd like to wrap up now. In conclusion, radiological imaging is absolutely critical to estimate the extent of disease spread. Do remember that if you have to debride the palate, get an impression made with a dental surgeon to get an obturator fitted, because that is important to rehabilitate the patient. A lot is being spoken about liposomal amphotericin and the cost of it, but we've been equally happy, and we've used in the past a lot of conventional amphotericin. Yes, the treatment becomes slightly longer, but maybe it actually also works a bit better. Open to analysis and review. Of course, this is having said that the side effect profile is manageable by the medicine people. Otherwise, liposomal is definitely better in terms of side effect profile. This disease has fatality, and we must be real about it. Literature states that once the disease is intracranial, the fatality can be as high as 80 to 85% despite the best efforts of the doctors. Our current fatality at Sion Hospital has been about 30 to 35% of our patients. But let's understand what causes this fatality. It's not because of the local rhino-orbital part of it, because that is to an extent debrided completely to the best of our ability. The fatality happens because of intracranial spread of the disease, because of the medical comorbidities that the patient has, like a diabetic ketoacidosis, or patients who are on dialysis having kidney problems. And we have seen currently a lot of thromboembolic phenomenon. Yes, mucor causes it locally, maybe COVID causes it systemically, and maybe it lingers on, because we've lost 3 to 4 patients who have been because of cardiac arrest, sudden MI, pulmonary thromboembolism. A stroke is possibly attributed due to mucor because it's intracranial spread, but the other 3 thromboembolic phenomenon actually had left us pondering over this a lot more. One thing which I spoke about when you have to review the diagnosis, because the patient profile is very similar when you look at immunocompromised diabetic patients, and yes, they may have similar complaints, but the findings may not be showing avascular necrosis or ischemia. And that's when the CT and the radiologists obviously help in this. The CT and MRI are invaluable to even pick up osteomyelitis. The CT shows with respect to the opposite bone the decalcification. The MRI shows a signal intensity in the marrow. And we must, as clinicians, keep this diagnosis in our mind when we are treating mucor aggressively, that osteomyelitis could be something. Bacterial or fungal, still to be debated. It is evolving, as I said, but osteomyelitis is something that could be also possible. Be a responsible surgeon, because it's possibly easier to operate, but it's important to take a decision of when and how much to operate. Treat the patient, not just the disease. It has to be kept in perspective about what patients we take up for surgery. Life over organ is what we believe in. The eye may need to be sacrificed in a lot of patients just to save someone's life, and yes, it's completely worth it. As surgeons, we must think rehabilitation when we are looking to take something off. So whether it is the palatal obturator, dental prosthesis, orbital prosthesis, or an orbital patch. One of our patients who was a musician earlier came with a very fancy
Dr.
orbital patch.
Yeah.
Yes. I am done with it.
Yeah.
Thank you so much
for
the time.
Thank you. Thank you so much for an excellent and very well balanced and mature presentation. Thank you so much.